Friends, welcome to the video presentation of Laryngocele Excision. This is a combined laryngocele where you can see the external and the internal component. Prior to going into the case, we will just look at this young male, 30-year-old male with swelling in the neck, which was increasing on Valsalva. And you can see on the axial sections that it is going through the thyroid membrane and it is involving the pharyngoepiglottic fold. This is on a video laryngoscopic examination that you can see that the illumination is present. On video laryngoscopy, you can see that there is a globular swelling which is present inferior to the pharyngoepiglottic fold, which is partially involving the vallecula and the lateral pharyngeal wall. The movement of the vocal cord is also a little restricted because of the mass effect. Now if you go into the surgical anatomy, so this is how the internal and the external components are communicated through the thyroid membrane, and we have to be very careful about the superior laryngeal artery and the internal laryngeal nerve when we resect. So starting with the incision, like a routine neck dissection or any neck surgery, we will try to give an incision, raise the subplatysmal flaps. So here a word of caution is you do not have to lift it till the level of the angle of the mandible or the lower border of the mandible, because our idea is not to divide the submandibular gland. So as soon as you identify the superior border of the cyst, here you can identify that the lower border of the submandibular gland and the upper border of the cyst are visible. So till this part the division and exposure is enough, and anteriorly we have to divide the fascia and expose the hyoid bone, because during the dissection and during the excision of the cyst we will have to denude some part of the hyoid bone. As we do a superior part, we are doing the inferior part as well. So the pink line which we are seeing is the platysma, and we do a subplatysmal dissection. This subplatysmal flap raising was initially difficult for me even in my residency period, because most of the times what happens is we use cutting current, and when we do not have control over the cautery, we do it more with a shoulder movement or elbow movement rather than using our wrist. We tend to overshoot and go through the platysma into the skin. So buttonholing and all were done during the residency period, unfortunately. But with time we usually understand how cautery works and we do better. Now this is the superior border of the cyst and also the inferior border of the submandibular gland. So here we divide the fascia. See, the philosophy of this surgery is we have to identify the cyst and divide it from the attachments with the surrounding structures. That's all. It is that simple. But what all structures we get during this division is important, and we have to preserve most of the structures which we get here. Superiorly, the submandibular gland, it is not necessary that we divide the submandibular gland or excise the submandibular gland. So here, thankfully in this patient we did not encounter the common facial, but otherwise sometimes common facial is encountered which is going into the submandibular gland, which needs to be clip ligated or suture ligated sometimes, but here it was actually going into the external jugular vein, so it was placed much later. So when we are lifting the submandibular gland, now you can see that the submandibular gland is being lifted. Here we did not get any common facial. This is an almost unedited video which is little longer. So with the help of blunt dissection only, I have taken a tonsil elevator here. So the You can see that white line, which is the posterior belly digastric, the intermediate tendon, and then the other oblique line, white line, which we are seeing is the hypoglossal nerve. So basically we are lifting even the deeper part of the submandibular gland, which is hooking around the mylohyoid muscle. In this kind of dissection we don't see the mylohyoid muscle because both the superficial part and the deep part of the submandibular gland, they are very much intact. So we just try to raise the submandibular gland and try to divide the posterior belly of the digastric and its facial attachments from the cyst. That's all. Now once the superior part is relatively free, we will come on to the lateral part. So this is the common facial which we are speaking about, which is not coming into the way of dissection, so we don't have to divide that common facial. Now once that part is done, we will try to divide it from the sternocleidomastoid muscle. So like we divide for any neck dissection, we will divide the fascia from the medial border of the sternocleidomastoid muscle. During this division, we all know that the segmental supply, blood supply of the sternocleidomastoid, primarily arising from the posterior occipital, from the superior thyroid and the transverse cervical. So those transverse cervical branches need not be sacrificed, but at least the superior branches, which are major blood supply to the sternocleidomastoid, have to be divided because it will bleed invariably again if we are not dividing. And it is important that we reflect the sternocleidomastoid muscle and expose the entire lateral surface of the cyst. The reason for why this fascia is maintained and remained attached to the cyst wall is because we cannot hold the cyst wall directly with Babcock or any other structure for the fear of breaking the cyst wall. So in order to hold them, to give some traction, we are keeping the fascia over that cyst wall intact, which will help us in mobilizing the cyst. So in this way, with the help of cutting current, in this case I have used a very low wattage of cutting current. It is almost on 10 to 12, and I have taken time to do cold swiping and cut the tissue rather than coagulating. Wherever it is required, I have used mosquito forceps to divide the facial attachments. If there is any loose areolar tissue, we can actually get some space properly. Avoiding tenting of the sternocleidomastoid muscle, we are gradually advancing the attachments of the muscle with the Babcock and trying to figure out where the inferior border of this lateral border is. Whenever we are doing this step, we should understand that we are in the proximity of identifying the internal jugular vein. Now here the facial attachments, actually you can very much see the underlying venous system when we are operating without damaging the venous supply. We divide the facial attachments. There are minor blood vessels which are running through the fascia, which can be bipolarized, or with the help of coagulation current you can just cut them. But it is very important that we do not soil the surgical field, because any soiling and inadvertent holding of the cyst wall may break the cyst wall, and then the surgery becomes little cumbersome. In like any other surgery, even this is like we are doing it layer by layer. Do not rush to divide the entire attachments on one side and then raise it completely. So we try to delineate from all the surfaces, superior, lateral, inferior and medial, layer by layer. We should also understand that since on the scan we have seen that there is also internal component which is attached through the thyroid membrane, we know that the rate limiting factor here will be on the medial surface. So once we divide it inferiorly, superiorly and laterally, then we can work along the medial side. Then we will have the hyoid bone attachments, in the thyroid cartilage attachments and all. As I told you before, the important vasculature which we are concerned here is the superior thyroid pedicles and the branches, that is the superior laryngeal artery and the internal laryngeal nerve that will pierce through the thyrohyoid membrane. Here the thyroid membrane anatomy is distorted because of this communication of the external and internal component. So a very careful dissection with the help of mosquito, or some people may do right away with the cautery itself, but then I was little skeptical and I was more confident and comfortable initially dividing the fascia with the mosquito only. So I was dividing the fascia, lifting it so that the underlying cyst wall is maintained, and asking the assistant to cut. Now here we can see that the strap muscles have come. This is the omohyoid muscle. Once we reflect the omohyoid muscle, then we will get the sternohyoid, sternothyroid and in this way we are dividing the facial attachments with the strap muscles also. So every time with the help of palpation, digital palpation, we reorient ourselves with the structures which are attached. We don't want to divide any muscle attachment unnecessarily. Only if it is very densely adherent, then we will try to divide that muscle. Otherwise, if it is very much amenable for peeling off from the cyst wall without breaking the cyst wall, then we would try to preserve the muscle, because any extra amount of muscle that is being dissected and resected will lead to some amount of dysphagia in these patients, and laryngeal elevation is a little affected. So here we are almost dissecting over the carotid fascia, carotid sheath. So we have to be careful that we may encounter the IJV, the carotids, and if they are more separated, then we will get the vagus also. And over the carotid sheath we usually find the ansa cervicalis. So as I told you, when we are doing layer by layer, we usually see any vascular structure or neural structure, and since this is not a radical resection, we are supposed to preserve all the vasculature and all the neural structures wherever it is possible. And it is very much possible that we preserve all these neural and vascular structures also. So here you can see that a nerve is present on the lateral wall of the cyst, which is divided and dropped down. As I told you, you cannot get entire surface like the medial wall or the lateral wall directly detached from its attachments. So it is like every time you have to come all the sides, divide it layer by layer, and then come. So there are little vascular structures which requires suture ligation. They are ligated. Now slowly we are able to deliver the cyst from its attachments. So the neural structures here we encounter are the descendens hypoglossal, the ansa cervicalis, and if the sheath is opened, the carotid sheath is opened, we will see the vagus. So whatever it may be, any of the neural structures need not be compromised here. They can be conveniently and comfortably preserved. This is only possible when we are doing layer by layer dissection, or else it is very easy for us to damage these neural structures, if not physically, functionally, by giving thermal damage to them. So only when we are confident that we are very much away from the neural structures, I am using monopolar cautery. Otherwise I will be using a bipolar cautery, and sometimes with the saline squirt onto the bipolar cautery when we are working, so that the thermal damage is minimized. I know I could have made a more concise and a small video, but then I just wanted to post almost an unedited video, so that these small nuances which are like working around the facial attachments with the cautery or with the help of a tonsil elevator can be shown, because this is very important in this. Ultimately in this cyst excision, it is only that we are detaching it from the attachments, that's all. But how do we do that is very important in this surgery. So as you know, we have, with the help of a Babcock's, held the strap muscles, and we are trying to do some kind of blunt dissection only. Cold swipes with the cautery. Now this is the laryngeal framework, the thyroid cartilage. This is also facial structure. So the facial bands which hold the cyst, they are slowly released from all the sides, and the cyst is little by little it is delivered. The key skill that we require in delivering such cyst is having patience, because ultimately it will be delivered, but how many of the important structures we have preserved while dissecting this out is very important. So rather than directly dividing all these muscular structures here, I'm just trying to see what vascular plane I can get through and divide it from the cyst attachments. The entire surgery took me over 2 hours 15 minutes, but the post-operative patient's laryngeal functions, respiratory functions and voice outcomes were near normal. So that actually reverts the surgery. I personally do not believe in telling that I have done the surgery in the fastest time or whatever it is, because half an hour here or there doesn't make much a difference to the OT or the resources, but it will make a lot of difference to the patient's life. So I believe in the concept that we do surgery meticulously than claiming that we have done surgery fastly. Actually, here if you can palpate, you can feel the pulsations of the carotid artery. So between the carotid artery and the internal jugular vein lies the vagus nerve, but it is placed more posteriorly. You usually do not see the vagus nerve even during neck dissections or whatever it is, until unless you specifically search for it. Maybe while doing the V1 and V2 for a thyroid surgery nerve monitoring, but that is also not done by many of surgeons. We usually see only R1, R2. This surgery mainly is also important in the sense that the assistant should be very good, because if the assistant with the cautery will overshoot and touch the wall of the cyst, then the whole purpose of this cyst excision will be defeated. So we have to then, after the cyst wall breaks, we have to excise it from whichever structure we think it is attached to, because when the cyst is intact we actually know the boundaries of it, where it is going and what it is attached to. So it is very important that we try and preserve the intactness of the cyst wall during the entirety of the surgery. So with the dissection with the help of a tonsil elevator, then monopolar cautery, bipolar cautery combinedly and in mix and match, the only idea of using all these structures is to safely separate the cyst wall, that's all. Now here we have seen dense attachment of the muscle fibers with the cyst wall, but luckily we could get away dissecting it also without damaging the cyst wall. But here we have to identify that we are almost in the carotid triangle, so high wattage of the cautery or inadvertent poking into the deeper structures or damaging the carotids or IJV or the vagus nerve should be carefully gauged and then done. Again the muzzle attachments. So earlier we have divided the muzzle attachments from the medial part. Now we almost came to the inferior part, that is its insinuation into the thyrohyoid membrane, or it is more appropriate to say that the laryngocele coming from the thyroid membrane to the external part of the neck, from endolaryngeal to exolaryngeal. So these muzzle attachments are also divided. Luckily the adhesions were not very thick and they were easily divided with blunt dissection also. You just insinuate the mosquito forceps and just release the facial attachments. Again this tonsil elevator becomes very handy sometimes. So only patience and careful dissection. Now here the attachments with the hyoid bone are in vicinity. Our idea is to divide the periosteum of the hyoid bone and drop the thyroid membrane down. Likewise divide the perichondrium of the thyroid cartilage and go into the paraglottic space. So these things should be virtually done before we enter into the OT. Whatever structures we are going to divide and how are we going to go inside the endolarynx should be initially imagined, because once you know what structures you are going to divide, you can also visualize and you can also contemplate what kind of reconstruction should be done in these cases. Reconstruction doesn't require a flap every time. With whatever structures which are present behind after the surgery, after the excision, in order to give a better swallowing and speech to the patient, we can use those structures to recreate the laryngeal anatomy and pharyngeal anatomy. So here this thick nerve, most probably here it is a vagus nerve, because it is present inside the carotid sheath. Over the carotid sheath, when it is present, it is thin, then we usually think that it is ansa cervicalis, and also the course we can see it is now. Since we are little deep into the structures, I would prefer using a mixture, that is right angle forceps, because the angulation to dissect is little difficult here with mosquito forceps or jake or whatever we use, and by far everybody has their own favorite instruments. Right angle is that favorite instrument for me. So small vascular twigs, they are suture ligated and divided. In resource constrained settings, sometimes we do not even get the free ties. So in those cases where they are using on needle suture material, this is how I tie. I don't usually do the normal freehand knots, because we'll be wasting much of the suture material that time. So with the help of forceps only I usually do that surgical knots. So the sharp dissection along the posterior belly of, this is the posterior belly of digastric seam. The muscles are divided from the facial attachments. We all know that when we track the posterior belly digastric anteriorly and superiorly, we will get the hyoid bone. So the cyst is also attached to the inferior bud of the hyoid, as we all know that this is insinuating or it is going through the thyroid membrane into the endolarynx. So definitely hyoid attachment superiorly and the thyroid cartilage attachment inferiorly will be expected, and as expected it is also present here. We need to divide the thyroid perichondrium and the hyoid periosteum. Yeah, this is the division of the muscle fibers from the posterior belly of digastric. Again, this is relatively a little boring kind of surgery because all that we do is divide the cyst wall, that's all. People may not find it exciting because more or less all the steps look similar. It is only that we are using mosquito, dividing the fascia, then delivering the cyst. But the laryngocele excision is all about doing this only. There is nothing more exciting in this. You can nicely identify the differentiation between the cyst wall and the muscle. So usually tell the assistant to cut it on the far away prong. Here it was superior prong of the mosquito forceps, so that we don't overshoot and hit the wall of the cyst. And wherever it is required, we will do blunt dissection with the help of this tonsil elevator. Tonsil elevator is very handy in excision of cyst and also for submandibular gland cysts like pleomorphic adenomas. Where we cannot insinuate the fingers because of the space constraints, we can use this tonsil elevator, or you can use Freer's elevator, whichever is more comfortable for us. But tonsil elevator, because of its more surface area, the damage to the cyst wall will be little less when compared to Freer's elevator. And when both are present, I will definitely want to use a tonsil elevator only. And these are the basic instruments which are present in any ENT/OT. Now you can see that white line superiorly which is visible is the hyoid bone. We came till the attachment of the hyoid bone now. Yeah, that is the hyoid bone attachment. Now this is the thyrohyoid muscle which is being retracted. Again, we don't want to divide these muscles because for two reasons. It is important in laryngeal work function, and also more importantly, it is not required to divide it during this surgery. It is only that we retract them, we go into the larynx, that's all. This thyroid muscle fibers are being retracted. Now here, as I told you, I am cutting the periosteum of the hyoid bone from the lateral cornua, from the lesser horn. Again, here you have to be very careful that we do not injure the hypoglossal nerve, the lingual artery, which are running on the lateral most part of this hyoid bone. And whenever we are just remaining hugging the bone, we don't usually injure those structures. We don't have to worry so much about those structures now. Yeah, just keep dividing from the inferior part. Here it is little difficult to dissect the fascia. It is not easily dissectable like you do on the other sides of the cyst, because the periosteum is little thick and it is more adherently attached to the hyoid bone. So you will require little use of cautery and some pressure when you are using the elevator. So again, as I told you, we cannot finish the entire work on one side and then go to the other side. It is always that you go around the cyst. Sometimes you work there, then you find that this is more approachable, this is more dissectable now, then you dissect this area, then go to another area. In that way, it is more about delivering the cyst outside. Definitely the work should be systematic, but it is not that we have to finish the entire work on one side and then come back to the other side. Once the lateral border is becoming free, we can hold it with a Alice forceps or with the ring of any forceps like mosquito forceps or medium size artery or whatever, but here we held it with the help of an Alice forceps. Gradually you can identify that the cyst is delivered more into the neck. It is becoming more and more mobile as you divide the facial attachments. Now you are more confident and convenient in dissecting. One thing to note here is sometimes it is always advisable to excise the cyst intact, but sometimes it is not possible, or without dissecting major anatomical structures, the delivery of cyst intact is not possible. So in those structures we try to decompress the cyst with some 5 ml syringe or 10 ml syringe and then excise the cyst. That is also important to understand, that you should not have ego with the surgery, or you should not feel that removing the cyst in entirety without decompressing it is more beautiful than cutting the anatomical structures and remove it intact. So you should know the philosophy of this surgery, that the cyst wall should not remain anywhere to the underlying structures because it may lead to recurrence. So that is the idea of doing this surgery. So you decompress, you don't decompress. If you just remove the entire cyst wall, then the job is done. So here the neural structure which is going into the thyroid membrane, that is the internal laryngeal nerve, which supplies the sensory supply to the superior part of the larynx. Yeah, that is being identified and it is being preserved. You should preserve that nerve. See, the whole point of doing meticulous dissection is to preserve the structures which are not involved. It is just in the way of doing surgery. It is not involved by the cyst, or this is not some radical resection or a tumor resection. So wherever possible, whichever new structure that is not involved should be preserved. So in that way, that superior laryngeal artery and the internal laryngeal nerve, which will pierce the thyroid membrane, they are preserved. In the initial part of this video, I have shown that black and white representation of the laryngeal thyroid membrane and the structures which are piercing through it. So those structures can be identified here. And again, it is a relatively little boring surgery, but then this is all about the surgery, right? So we have to be little patient. More than the surgeon, the assistants have to be little patient. We are just working around the cyst all the time. More or less the attachments on the superior, inferior and the lateral part are done. Now we are dividing it from the, see, this is the thyroid cartilage and we are dividing from the thyroid perichondrium now, inner perichondrium of the thyroid membrane. So perichondrium is being lifted with the tonsil elevator. Be gentle with the muscles. We will even ask the assistant to just be gentle with the retraction. Don't use more pressure. Because by this time they would lose the patience and get frustrated with the surgery. So they'll be more harsh with the tissues. So we just request them to be little gentle with the tissues. Yeah, so that's the thyroid perichondrium. This is the internal laryngeal now. So whenever you feel that you are stuck in one structure, then go to the other surface where you can divide the fascia. Then at last you can come to this point. So here again, this is the lateral border of the thyroid cartilage, from where we are just trying to divide the pharyngeal constrictor attachments, because the systole is densely adherent here. We know that the main vascular structures and neural structures are preserved, so the other things we are gradually dissecting them out. Yeah, this is from the outer thyroid perichondrium. The superiorly you can see the hyoid bone. With the help of little more pressure, you can just pierce the attachments of the thyroid membrane here. We are dividing the thyroid membrane. So with all these forceps we are giving some traction and counter traction. We all know that head and neck surgery is all about giving traction, counter traction and sutures, that's all. And having anatomy and anatomical orientation of the structures which are dividing. So the greater cornua is being detached from the attachments So in this phase the thyroid membrane is being divided. Yeah. So all these dense attachments of the thyroid membrane and the musculature to the cyst wall, they are bipolarized and cauterized and divided. Here it is better we divide the attachments as close to the cyst as possible, so that more amount of muscle is preserved, and that gives us more freedom in reconstructing the pharyngeal wall and the laryngeal framework after the excision is done. So we want more normal structures to be preserved. Now almost inferiorly the attachment of the internal laryngeal nerve with the cyst wall is separated. Now the cyst is 90% out of the attachments. Now we are only held by the cyst wall attachments with the endolaryngeal component, the internal component. The external component is almost done. Now we are working over the thyroid cartilage. We can palpate the thyroid cartilage. Yeah, that's the thyroid cartilage lamina. I am using a Dissection or a vascular forceps to hold the structures. Sometimes, unfortunately, other than holding the structures, we cannot give them traction. So we can parallelly use some vessel loops or use a skin hook to retract them. So here we are directly trying to enter the paraglottic space. As per the general description of the excision of the internal component goes, so what it is being described is we can cut the thyroid cartilage like a V-shaped cut over the thyroid cartilage, excise the entire part, and then again use a Prolene stitch to reconstruct it. But then here I did not get any requirement of such kind of dissection of the thyroid cartilage. The entire cyst wall was conveniently excised even from the endolarynx, from the laryngeal part. Without any difficulty. Because always the space is being made by the tumor itself. I'm sorry, it is not tumor, it is only cyst. So the cyst by itself makes some space, and we just have to follow the cyst, that's all. We do not make any new connections, or we do not make any new communications here. The cyst has already made few communications and we have to follow them just to go inside. So this is the fat from the paraglottic space. That fat need not be divided. You have to divide the fat from the cyst wall, that's all. So again, with the help of blunt dissection, we are trying to see where the fascia would be. And so this is the attachment now. We just divide this attachment. So in this way, technically it is not correct to call this as endolarynx, but then we are in the larynx. So endolarynx usually is when we go through oral route into the larynx through that way. This we are going from the cervical route only. So technically it is not endolarynx, but then we are working inside the larynx. So in this way, without dividing any thyroid cartilage structures, we are able to get away dissecting the medial surface of the internal component of the laryngocele. Just before dividing, every time I palpated whether I am not cutting the vocal cord structures, because you can see that there is some insinuation of it inferiorly that is being divided gradually with the help of a bipolar cautery and cutting its attachment. With digital palpation, which you can also identify the vocal cord structures and you do not damage the vocal cord here, the vocalis muscle. So in this way, gradually the cyst is being pulled from the internal component into the neck. The external component is already out. It is completely divided. Now the internal component is being divided. So a little more patience. Now this structure we are dividing from the pre-epiglottic space and the paraglottic space. After division, we can actually see the intact mucosa and the epiglottis as well. So inferiorly we see the thyroid cartilage, the epiglottis, and superiorly we see the hyoid bone. So gradually we are dissecting it out, and fortunately in this case, without damaging the cyst wall anywhere during the surgery, we could get away excising the cyst entirely. Then actually this is one part of the surgery. The main part is again we have to reconstruct. Here the reconstruction is very straightforward. After the excision, we could identify the cut surface of the muscles, thyroid membrane, that have been reconstructed with the help of PDS suture. So these muscles were used to reconstruct, and the pharyngeal constrictors which were cut from the lateral wall of the, this is hyoid bone, this is the thyroid cartilage, this is internal laryngeal nerve, and that structure is the epiglottis. The mucosa is intact, and we confirmed the intactness of mucosa by doing a Valsalva with water leak test. So we put some saline, we try to give Valsalva, and we see for any water bubbles, because that has to be repaired on the table. We cannot extubate, wait for it to granulate or repair by itself. We have to repair it beforehand. Now these muscle structures, they are repaired, a thorough wash, repair of the structures, and then closure. This patient was doing very much fine in the post-operative period. We have done video laryngoscopy. The voice was intact, the patient was not aspirating, but preemptively we put a Ryle's tube. Patient is doing good. He has been discharged in a very satisfactory condition. Thank you for watching this video. Thanks a lot.